各位贵宾以及医疗器材产业先进，大家好，欢迎参加2021年疫起掌握欧洲医材新商机线上研讨会。本次研讨会由经济部国际贸易局主办，外贸协会执行。我是今天的研讨会司仪雅梅。接下来的1个小时，我们邀请到英国和荷兰重量级讲师，和各位一同来探讨现今欧洲医材市场。特别是英国脱欧之后产生了什么影响？疫情之下又有什么变化呢？首先，我们有请英国伦敦台贸中心黄汉堂主任为我们简述英国目前市场重点和贸协相关服务，并将由英国医材公协会 Association of British HealthTech Industries ABHI 主席 Ms. Luella Trickett 为我们深度剖析英国医疗市场以及政府采购商机。
各位业界先进，大家好，我是伦敦台湾贸易中心黄汉堂，很高兴在线上和大家见面。那英国从去年3月爆发新冠肺炎的疫情之后呢，就一发不可收拾。在经过了3次的封城之后呢，终于随着疫苗的广泛的施打呢，疫情在最近这1个月已经有明显的缓和了。那在这1年多来呢，累积的确诊人数已经达到了400多万人，高居全球第6，死亡人数也达到了12万7千多人，高居全球第5。在疫情的期间呢，为了避免防疫物资的缺乏，英国政府特别规定个人防护跟检测用品呢是免税的。那此外呢，在疫情的期间呢，数位和医疗远距的医疗的应用呢有很大的提升。那例如医生们使用远距诊断的比例呢，从原本不到20%上升到超过50%。那英国的医疗器材进口的金额每年大约是50亿英镑，出口额每年大约是40亿英镑。主要的进出口的贸易的对象是欧盟，占总额的50%以上。随着英国的脱欧过渡期在去年底结束呢，未来英国对欧盟的贸易依存度的下降的幅度呢，还值得我们后续来观察。那英国脱欧还有一项重要的变化呢，就是 CE 认证在英国的使用。CE 认证在英国只能使用到2023年的6月30日，在这之后呢，所有包含医疗器材在内的产品都必须要取得英国本地专属的 UKCA 认证，才能在英国市场来贩售。那谈到英国的医疗器材市场呢，就不得不提到 NHS， 也就是英国的国民保健署。NHS 呢是英国医疗器材市场最重要也几乎是唯一的买家。那因此呢，要进入英国的医材市场呢，必须要先了解如何成为 NHS 的供应商。如果要直接供应给 NHS， 就必须要先成为 NHS 供应链的候选厂商，才能够获得第一手的标案的资讯。那在得标之后呢，来正式成为 NHS 的供应商。那如果不想直接接触到标案呢，也可以考虑作为 NHS 供应商的下包商。但是 NHS 的供应商呢，有很大一部分是制造商，那不见得需要向下包商来采购，因此呢，作为下包商的机会是受限的。那有关于英国的防疫的用品以及医材市场更深入的剖析，我们今天很荣幸的邀请到英国医疗科技产业协会负责政策及市场评估的主管 Madame Luella Trickett 来为我们做详细的解说。那各位在听完了他的演讲之后呢，如果对拓销国际市场有兴趣，除了参加贸协举办的线上洽谈会以及台湾国际医疗展 Medical Taiwan 之外呢，如果有兴趣针对个别市场来拓销，也可以报名外贸协会的 IMD Plus 或者是小型机动拓销团。那目前这2项服务呢，在疫情期间都是采线上方式进行的。 那最后，各位如果对拓销英国的市场有任何疑问呢，都欢迎跟我们联络。谢谢。
Hello, my name's Luella Trickett, and I'm the Director of Value and Access at the Association of British HealthTech Industries. Today, I'm going to share with you some background about the impact of the recent epidemic on the UK and the National Health Service. Last year, in March, the UK experienced the first of the wave of the coronavirus that we had seen coming as it spread across other countries. The National Health Service was ready for it and preparing to deal with it, but it did so in quite a drastic way. All of the patients in the hospitals that could be sent home were sent home. That included sending a lot of elderly patients back to care homes. All routine activity was cancelled. The only routine activity that carried on was critical treatments for life-saving purposes. That did mean that the National Health Service became a full COVID service. The NHS adopted policies to increase intensive care capacity. At the beginning of the epidemic, we had a relatively small number of intensive care beds versus what we had seen being needed in other countries like Italy. And so hospitals set about making sure they had a greater number of intensive care beds. We also built field hospitals in big exhibition centres to enable any overflow of patients to be treated. As the first wave of the epidemic subsided in June of 2020, the National Health Service did begin to recover some of its elective services, and so some routine operations started again. There was significant focus on treating cancer patients and treating patients with cardio or neurovascular conditions. The second wave began in October 2020, and I'm sure many of you have heard that this coincided with a designation of a variant that seemed to transmit faster. And very quickly, yet again, the National Health Service had to cancel all non-urgent treatment. What also happened to support the treatment of patients was that primary care, so general practitioners, stopped seeing patients face-to-face in their surgeries and transformed their appointments as much as possible to telephone consultations. Now, these were not necessarily video conversations. They were simply using the telephone instead of face-to-face. When there was a possibility for routine operations to start again because COVID was less prevalent, the NHS also contracted with private hospitals to make all private capacity available to the NHS. And that has continued to this day. At the same time as transforming the services, the government set about making sure that all the required equipment was available to the National Health Service, as did much of the rest of the world. And actually, at the time, the whole of the world was trying to source the same equipment at the same time in very large numbers. The UK government procured, in some cases, what they would usually buy over a period of 3 years within a matter of months. They did this using legislation that allowed them to relax procurement law so they could do direct awards with no competition. PPE was sourced from all over the world. The UK also started to manufacture some of its own PPE that previously it had not had any manufacturing capability for. The government issued a ventilator challenge where it brought different industries into making ventilators locally in the UK. This was often collaborations between different industry sectors. So you had traditional device manufacturers of medical equipment working with the automotive industry in some cases. And this was very successful, and it involved the regulators in order to make sure that those ventilators were fit for purpose and could be deployed as quickly as possible. The government also invested in the development of vaccines and in the manufacturing of vaccines. And in fact, the manufacturing of some of those vaccines commenced at risk before the regulatory process was concluded. And that did enable the UK to start the vaccination program almost immediately once the approval of those vaccines took place. The government also invested in diagnostic testing and track and trace infrastructure. That investment took a while to really demonstrate the value, but it quickly did. And we now have a very comprehensive diagnostic testing program, including both PCR and lateral flow, and a good track and trace infrastructure. And that is being deployed very widely right now to make sure that any variants are detected and tracked and traced, all people in the country once they've been spotted. During the pandemic, patients still needed to be treated. Patients with ongoing conditions that usually needed face-to-face care had to be reimagined. People were told to stay away from hospitals where possible, and remote management and monitoring technologies were rolled out for patients with long-term conditions, such as diabetes. Artificial intelligence solutions were put in place to enable specialist clinicians to assess scans remotely and be able to give guidance to more general local healthcare teams for the management of patients with conditions such as stroke. And digital solutions were used to allow the monitoring of blood pressure and the identification of atrial fibrillation at home without the need for a face-to-face appointment, so that patients could avoid going into hospitals and avoid going into other clinics. When the COVID crisis of the first and second waves started to subside, cancer treatment was prioritized to restart. We know that there are many cancer patients that have yet to show the signs and symptoms and get referred, but those cancer patients are still there. They implemented technologies to facilitate the diagnosis and treatment, avoiding using traditional technologies, so colon capsule endoscopy and cytosponge, to clinically prioritize diagnostics. Technologies to manage the release of aerosols have been employed in a lot of clinical settings where aerosols are expected, including in surgery, but also in places like dental practices. What the NHS also did was try and undertake procedures using minimally invasive technologies to reduce recovery time and ensure that patients stayed in hospital for a shorter period of time. And an example of that would be the rise in the use of the TAVI procedure versus open surgery for patients other than high-risk patients who historically would have been the only patients prioritized to have a TAVI procedure. Cancelling all of the non-urgent treatment during the pandemic has led to a significant rise in patient waiting times. The NHS used to have a target for referral to treatment of 18 weeks. Now we have many patients waiting over a year for their treatment. In fact, we have the highest number of patients waiting for elective procedures that we have had since 2007. Certain procedures, because of the Royal College of Surgeons' prioritization of criticality of treatment, have been almost stopped altogether. And some of those, the musculoskeletal and eye care operations, have been called out as priorities for pathway transformation using digital solutions, alongside cardiac procedures that did continue throughout the pandemic because they were often considered life-threatening. A roadmap for the recovery of elective care procedures has been set out, although we do not expect full recovery until 2022 at the earliest. And in fact, we have now got targets for recovery to pre-pandemic elective surgery levels of around 70% by the middle of summer this year. What has been made clear during this pandemic is the importance of diagnostics, not just for managing pandemic patients, but also for better managing patients who have other clinical conditions to deliver quicker and more targeted care. And the UK government and the NHS now recognises the importance of diagnostics as an early tool in managing clinical patients, and will be looking to roll that out more significantly post the pandemic. The large amount of equipment that was bought in the very early stages of the pandemic back in March last year has now been distributed to hospitals for permanent use, apart from the equipment that was bought that does not suit in normal times, which is being held currently as an emergency stockpile. This does mean that a lot of equipment is now in the National Health Service that will not require replacement in the near future. And that has shifted the expected demand for some of the equipment over the next few years. The stockpiles of PPE that we have now amount to several months' worth. And in fact, some products, we believe there may be years' worth of supply within the UK. There are still some products in shorter supply, such as gloves and gowns to a lesser extent. The UK is looking at what it needs to put in place for future pandemic preparedness. And the government is reviewing what it needs to stockpile and how it will manage those stockpiles, what domestic manufacturing capabilities it may need. And it has also called into question the amount of single-use products. And coupled with the NHS's net zero and environmental sustainability commitments, there is likely to be a move towards more reusable technologies and technologies that can easily be remanufactured. So, with all of the pandemic going on, the NHS was also going through a big change of its own. It published a report a couple of years back setting out its long-term plan, which has the priorities and the way in which it wants to change the delivery of care. There is an emphasis on digitally enabled care, and that is necessary to be rolled out as a mainstream treatment mechanism across the NHS. Some of that was fast-tracked as a result of the pandemic, going overnight from GPs seeing all of their patients face-to-face in a GP surgery to doing more than 90% on the telephone went a long way to helping that process start. As I mentioned earlier, there's an emphasis on early detection and diagnosis, and the priorities for progress in care are explicitly called out for the following conditions: cancer, mental health, multimorbidity, healthy aging, including dementia, children's health, cardiovascular, respiratory conditions, and learning disability and autism, with an aim to treat things like mental health on a par with physical health. We do believe that traditional medical devices will remain the mainstay of treatment over the next 10 years, but we do believe there will be significant advances in innovative surgical interventions, and examples of that include technologies that reduce the number of incision sites during a surgical procedure, a much greater use of robotic surgery, and an explosion of the use of 3D printing. And we do believe there will be a convergence of traditional devices, diagnostics, and information technology in combinations to deliver care. In the UK, the top 10 global medical technology companies are all represented, and you can see their names on the slide here. Multinational companies from around the world are all represented in the UK market. The NHS procures from medical technology companies in a number of different ways, either directly by the hospitals, or more commonly, the main route for buying products in the NHS is an organisation called Nhs Supply Chain. And the link is here, and you can see all of the contracts and all of the manufacturers involved in those contracts there. And while I say that all of the top 10 medical technology companies and multinational companies are represented in the UK, it's also important to call out that about 90% of the sector are small and medium-sized companies, and they are also well represented in the marketplace. The government has a target for buying from small and medium-sized companies across all public procurement, and that target is 30%, and it is a measured target that is reported upon by Nhs Supply Chain. Next slide, please. In England, the largest procurement organisation is a company called Nhs Supply Chain. It's made up of a number of different procurement organisations called category towers, and each category tower is responsible for buying on behalf of NHS England specific categories of products. For example, one of the category towers will be responsible for buying orthopaedic equipment. Another category tower will be responsible for buying all of the cardiology equipment. And yet another one would be responsible for buying, let's say, ward hospital-based consumables like IV sets and intravenous pumps. But as well as the Nhs Supply Chain category tower procurement, there are other ways of procuring medical technologies. Companies like HealthTech Europe and Shared Business Services are two organisations that undertake procurement. HealthTech Europe acts like a GPO that also supports a lot of back office services on behalf of a lot of the NHS hospitals. The changing NHS infrastructure in England means that individual hospitals, community hospitals, and social care are coming together to form integrated care systems or sustainability transformation partnerships. And they are looking at aggregating regional volume and buying on behalf of a region rather than just as a hospital trust. Then we have other collaborations, such as groups of hospitals that come together and buy as a group. The Shelford Group is one of those, and it is made up of some of the very well-respected university teaching hospitals. And then finally, you have local trust-based procurement, so the individual hospitals undertaking their own procurement. One thing that's very important to to comment on is that we are seeing much more focus on procurement that is underpinned by value-based principles. So looking at the outcomes of the health technology across the patient pathway rather than just the cost of the technology. So taking on board the most economically advantageous tender approach. Next slide, please. Now, while the NHS in England is by far the biggest NHS organisation, we do have procurement that takes place in the devolved nations. In Northern Ireland, you don't have the same difference between hospitals and primary care and social care. So Northern Ireland buys as a whole entity, and the procurement organisation in Northern Ireland has a range of contracts and provides local support and advice to the local hospitals in Northern Ireland. In Scotland, National Procurement Scotland undertakes all of the procurement for the Scottish hospitals, and much like Northern Ireland, you don't have the difference between commissioners and providers. National Procurement Scotland procures on behalf of all of the Scottish health boards, and the innovation access in Scotland is through the Scottish Health Technologies Group. And they too have a good focus on considering value rather than price. Again, much as Northern Ireland and Scotland, in Wales, the commissioner-provider model doesn't exist, and Wales procures through its health boards. And Wales is the most advanced when it comes to value-based healthcare. They have a dedicated procurement team looking at procuring for value. They are thought leaders in this space. I'd like to talk to you a little bit about the academic health science networks. The academic health science networks were set up a number of years ago now with the objective of bringing the NHS, industry, and academia together to identify and spread health innovation at pace and scale. They are dedicated to driving the adoption and spread of innovative ideas and technologies across large populations. They are 15 in number, but they act as a network. So while they are individual organizations in their own right that are dedicated to their geography, they do work together and make sure that they share ideas and best practice across the whole network. The way in which the academic health science networks support medical technology companies is through helping them with evidence generation. For example, they may be able to partner an innovator with an NHS hospital to run a clinical trial or to do some real-world evidence gathering. They can also offer advice for innovators, so they can talk to you about your technology, help you understand your market, help you understand whether the innovation is ready for the market or whether there's more to be done. They also support a number of the accelerated access collaborative programs at a national level, one of these being the rapid uptake products. They are particularly helpful for small and medium-sized enterprises because those organizations are the ones that find it the hardest to navigate the system, particularly from a resource point of view.
相信大家听完以后对英国市场有更进一步认识。接下来我们将目光移到荷兰市场，由荷兰鹿特丹台贸中心严明化主任为我们带来疫情下荷兰市场变化的第一手讯息，并将由身兼 Tomorrow Medical 执行长和 FHI Medical Technology Association 医材工会医疗技术部门主席 Mr. Vroet 以科学化数据以及深厚的市场资源，为我们深入掌握疫后荷兰医疗市场。
各位厂商、各位先进，大家好，我是鹿特丹台贸中心严明化，很高兴借由今天的机会和大家分享荷兰目前的医疗市场。荷兰大约有1750万的人口，其中65岁以上占总人口的 20%。2020由于疫情的冲击，荷兰的经济成长率为负的 3.8%。依据世界卫生组织4月21日的统计资料显示，荷兰累计的确诊数为141万以上，死亡人数为16000多人。以4月21日为例，单日的确诊数为7100多人。荷兰政府对于疫情提出很多的措施，例如居家上班、全面封城，甚至于宵禁。很可惜的是，直到今日，始终无法有效的管控疫情。荷兰的医疗体系呢非常完整，民众病不论大小病，只能先找家庭医师，再由家庭医师转诊到专科医师或者医院，分层非常清楚。目前，荷兰的医院约有300家，照护机构约有3000家。对于医疗器材的采购，则由荷兰的医院及照护机构自己的采购部门，或者向医材供应商采购。由于荷兰的医疗跟保险制度，一般民众为了要向保险公司申请医疗给付，对于医疗器材的需求，也是透过医院或者是照护机构等医疗体系购买。因此在荷兰比较少看到医材的零售店。至于荷兰对于医疗器材的设备进口呢，较高阶的医疗器材跟设备呢，荷兰我们大部分是向美国、德国及爱尔兰等国际大型的医疗公进口。一般消费性的一个医材呢，则由医院的采购部门或者是向医材的供应商采购。那至于疫情期间个人防护的产品，也就是 PPE 呢，由于价格的因素，大部分是向中国大陆进口。那在疫情期间，荷兰政府呢也紧急成立 LCH 国家医材中心，统筹负责所有医护人员的个人防护产品的一个采购。在这样的一个疫情状况下，台湾的业者的机会在哪儿呢？我想针对欧盟等西欧的国家，台湾的业者应该有不同的策略。我们可以运用我们本身的优势及利基点切入欧盟市场。例如，众所皆知，台湾在 IT 产业上的发展跟应用非常的亮丽，而且在国际上也享有声誉。荷兰对于跟台湾业者在远距医疗的应用以及医疗技术的合作充满期待跟兴趣。所以我们建议有意进入欧盟的厂商，您可以事先规划符合欧盟法规认证，同时也要及早建立售后服务的一个机制。今天我们很高兴邀请到荷兰非常重要的工会 FHI 向下医疗技术部门的主席 Mr. Vroet。他从2006年到现在担任医疗技术部门的主席，同时也担任医疗新创公司的 CEO。在2012年，他更担任飞利浦集团向下医疗公司的总经理。在产业界的实战经验非常丰富，我相信他今天的简报可以为各位带来一些新的市场讯息。最后，鹿特丹台贸中心祝各位生意兴隆、平安健康。接下来我们将镜头交给今天的讲师，谢谢大家。
Hello, welcome. My name is Rob de Vroet and I'm the CEO of Tomorrow Medical. Tomorrow Medical is a software company in which we sell software for early born babies, in which we can predict infections upfront before they have clinical signs. Next to that, I'm the chairman of the FHI, Medical Technology. That's a branch organization in the Netherlands. Currently, I will be talking about the FHI and about the Dutch healthcare system and the way we work and what you could expect as a Taiwanese company to be entering this market. First of all, I will tell you a bit about the FHI, how that's functioning, how it's looking, and who is present in there. Then I will tell you a bit about hot topics in the Dutch healthcare currently ongoing. Some background on the Dutch healthcare system, some figures about that, some trends, and at the last part I will give you some information of the products that are needed, but also on how COVID is being treated and attacked here. Well, FHI is an umbrella organization, and there's a lot of companies present in there. In total, there are about 800 companies in that organization, and it's split up in 4 branches. One of the branches is industrial electronics. We have industrial automation, lab technology, and medical technology. And currently, we're talking about the medical technology branch only. Well, what do we do for the companies that are members? Well, member companies pay a little fee to be members, and for that fee, we can do stuff like economic research, we follow statistics, trade fairs are being organized in conferences, not so much for the medical field, but conferences we do. There is a social policy, so we help companies on the HRM part, so on the people management part, with salaries on salary averages. So if you need to know what is an average salary for a sales rep in the Netherlands, there you can find it. There is been built purchase and delivery conditions. So that's a uniform template that's been used with all the hospitals in the Netherlands. Further, we have a technology policy, which we do in the political climate. So what we do a lot of lobbying at the government level to see that medical technology is important, stays important, and stays on the radar. Furthermore, we give legal support to the companies. There are joint purchasing services. So for smaller companies, you can have absenteeism or pensions, a range of that. Legal support. We give information and workshops for our members. For example, on the MDR, all those changes, that's a lot of change for a company. We educate them in that, and next to that, we do the publicity. So how is it structured there? As you can see in this screen, there's one overcoupling organization, which is the federation. And in that, there are 4 trade associations. And we are in the right part of that. That's the medical technology part. There is a membership meetings are there twice a year. And almost all companies take part in clusters. And the clusters are specialized working groups, which are, for example, X-ray technology, echo, but also Band-Aids or breathing and ventilation groups. So their companies can meet, they can discuss their common problems, and they can address a way of going forward to the politic people. For the medical branch, we have 140 members. Initially, we started from the medical devices, so it was everything containing a power inlet, let's say. Currently, I think it's about 50-50. There are medical device companies, but there will also a lot of disposable companies in there. They're larger and smaller, and we touch almost all markets in the Netherlands. So in the Netherlands, you have the hospital market and you have the home care market, which has typically a very different approach. In the home care market, the insurers are very important and are very influential. And in the hospital markets, they are basically not influential. They can try to steer something, but in the hospitals, you have a different purchasing organization. So it's a complete different ballgame. In the board of the FHI currently is, well, I'm there with Tomorrow Medical. Entermet is in there, which is a medium-sized company. Siemens Healthineers, which is a huge company. Medic is the biggest supplier in the Netherlands on disposables. Draeger, you probably also know, is quite a big international company, as is Fresenius and Canon. Currently, you have 15 cluster organizations in which they are specific topics discussed. We are part of MedTech Europe formerly Eucomed, and we are also part of COSIR. Well, what are the current hot topics here? One of them is, let's say, for our politicians, the hottest topic at the moment is the Code of Ethical Business Practice. And that's because we have seen quite some instances in which there were things not going according to plan and doctors being bribed and that sort of stuff. So they wanted to ban that out. And built on that, there is a Code of Ethical Business Practice built. Next to that, reimbursement is, I think, in every country in Europe, a big issue, but in the Netherlands as well. Furthermore, we focus a lot on investment and maintenance of medical equipment, because we found out that some of the equipment is basically very old. So we found echo and x-ray machines of over 10 years, while the maximum life expectancy of these devices is 7, according to the suppliers. So if you have a device of over 10 years old, it's really too old for the modern medical market we want it to be in the Netherlands. We have some issues with counterfeit, in which we have seen that, let's say, products being built by an international supplier, for example, Medtronic or Draeger or whatever, has been copied by a Chinese company. And basically, we don't want that, because we don't want to have counterfeit products being part of a system, because then you're never sure if the warranty is being held and everything. So that's a hot topic to ban out. And next to that, obviously, like everywhere, COVID-19 is a hot topic at the moment. Well, if you go to the code of conduct, you can see that advertising and promotion is permitted. But the basic background on that is that the politics and the people want to be sure that the doctor is not being influenced by a medical device company. So if you get a pacemaker, you want to have the right pacemaker for your situation. If you get a stoma, you want to have the right stoma treatment for your patient. If you get You don't want the doctor to have interference financially with medical device companies. And that's basically built up in the code of conduct, and that's a GMH, that's a Dutch code. But that code is also connected to the Eucomed code, the COSIR code, and the ABHI. So basically, it's quite a strict code on how you behave in the Dutch healthcare market. If you go on to reimbursement part, in the Netherlands, we have a reimbursement system in which there is a governmental organization. We call it, it's a difficult Dutch word, Zorginstituut. That's basically a government organization that has a crucial role in deciding if a treatment gets funded by the healthcare insurers. So basically, they say this treatment is being funded, and then the healthcare insurers are obliged to pay. In the Netherlands, that means that almost everything is being paid that way. Only specific, very new, often unproven technologies can be sort of in the waiting room, but basically you can get every treatment in the Netherlands which you need. There is a reimbursement system based on the DBC, basically, and which the hospitals decided the pricing that's being negotiated with the insurance company, and based on that, the hospital gets reimbursed. So, for example, for a hip replacement, the hospital gets one price, and the price is around, I think, 20,000 euros, and they need to do everything. They need to do the admission of the patient, the operation, the treatment afterwards, and whatever. So it's important to have, for the hospitals to have a one-shot treatment, do it the cheapest but most effective way. Because if it's running into an infection, they will need to pay that out of their own pockets. At this moment, it's quite difficult. There is some sort of boundary to get market access with new expensive devices. And that lays basically in the MDR, but also in the reimbursement system. First, you have to prove it. So we have an evidence-based healthcare policy. So if you don't have evidence that your treatment is working, it will become very hard to get it in the Dutch market. What we want to show with this is that on the left you'll see some sort of breathing thing, and we say, well, with this stuff you are not going deep sea diving. So you also don't want your patients to be have a breathing therapy with a very old, out-of-date machine, right? And the same we do with, you have a broken bridge, you don't want to walk on the bridge, but why do you use a very old machine which is out of date? And that's based on something that we have a lot of publicity on medical equipment in which there were failures. And basically it all came down on that those medical equipments were not well being maintained, or they were very old. So based on that, there is a tendency in the Netherlands to stick to the life expectancy of these devices. Well, talking about life expectancy in the Netherlands, you can see that the life expectancy is actually quite well. It's increasing over the years because the orange bar is about 15 years ago, 20 years ago, and the black bar is around the current state. This is the life expectancy for men, which is currently a little over 80, and the life expectancy of women is still a little higher, but it's basically narrowing into the men. We think that is because women are currently as much smoking as men. So in the old days, let's say 40 years ago, there were much more men smoking, and currently that's basically even. There's about the same amount of men, women smoking. And if you then look into the market, you see that in the Netherlands you have basically 78 hospitals currently. And that's academic hospitals and general hospitals. But we come from around 200 hospitals. And what you see is that because of that, the size of all the hospitals is increasing dramatically. So in the Netherlands, you will not find a hospital with 100 beds. The small size hospitals already have 400-500 beds, and the large size hospitals have around 1,200 beds. So basically, you always talk about hospitals with quite a significant size. What we also see is that the hospital expenditure, which you see on this graph, is sort of leveling off. And that's because of price erosion, the influence of the insurance companies that are not willing to pay more and more and more, and because of more efficient working in the hospitals and in the healthcare system itself. So we try to be very efficient. That's basically, sometimes I say kiddingly, efficiency is the middle name of the Dutch. We try to do maximum output with minimum input, and with that we try to have a maximum result. And here you see how we do that. You see the average day people are staying in the hospitals, and that's going down over and over and over. Currently, the average stay in the hospital is under 4 days. And that's everything, right? So that's difficult infection, difficult patient, but also an appendicitis or something, right? If you look into our population, you can see that we will have some challenges in the Netherlands. If you look here, in 2020, we will still have quite a lot of elderly people, which is growing, but from 2020 to 2030, 2040, the number of elderly people will increase dramatically because of the baby boomers becoming of age. And our working population is going down. So in everything in the Netherlands, we will need more efficient ways of working and ways of doing stuff. So therefore, we try to do everything with the minimal people input. So we are very technological driven. If you can use a device or something else to have that done, we are there to put it into place. If you now look, how is it financed, everything? We have, every Dutch citizen has a mandatory healthcare expenditure insurance policy. And that's a base policy. It's obligatory, so everybody has one. Some very poor people perhaps don't have one and they will be treated anyway. So it's not like in the US that if you have no money, you're not treated. Everybody is being treated, but everybody is obliged to have a healthcare insurance. If you don't have that, it will pop up at government level and you will be challenged on that. This basic insurance takes care of the family physicians, so the house care physicians. It takes care of hospital care and also of normal pharmaceutical expenditure. You can insure yourself more, for example, for physical therapy, for if you want something strange like non-regulated healthcare, you can have a private insurance for that. The healthcare expenditure budget is growing with an average from 6 to 10%. And that's basically because of the cost of healthcare, but also cost of people. It's people work for a lot, so that's increasing on average. Must say the last years you'll see it leveling off because we have had a big stroke of more efficacy in the market. So it is leveling off. On average, it was 6 to 10%. I think now it will be somewhere around 4%. And then this is an example on how we try to change things. This is the number of operations, so surgical interventions in the Netherlands from 1995 to 2007. And you see that over 50% is being done in a day treatment. So the people actually doesn't get admitted in the hospital. And currently this trend is still ongoing. And I think it's about 60% of treatments is being done in day treatment. So people come in the morning, get their treatment, get home at night or in the evening. If you look into the expenditure in healthcare, you see that the Netherlands are on the far left side. We spend a lot of money in healthcare expenditure, and that's because of that basic insurance. So people, everyone, let's say the minimum price for that basic insurance in the Netherlands is around €1,000 per year. Most people pay more, so it's I think on average people pay around more than €100 a month per person for all adults. Children are free. The other part of that healthcare expenditure comes from the taxes, so from the government. On average, you must say that the Dutch people pay income taxes from around 37.5% of their income till 50% on their top income. Okay, how is the market then structured? You have the insured patients on the left. You have the hospital providers or the healthcare providers on the right. There is an interaction. People have a free choice which physician they want to use, which hospital they want to use. And on top of that, you have the insurance who need to pay it. So there is also some sort of triangle. They want to purchase cheap with the hospitals. They want to sell their insurances for a very attractive price to the patient, but the patient wants to have everything covered. So you can understand there must be some regulation on top of that, and that's been done by the government. So what are now the trends? So for healthcare suppliers, there is an increasing financial risk because the insurance wants to diminish their own risk. So they want to put the risk at the healthcare suppliers, so the hospitals or the home care organizations. There is an increasing demand for quality. So in the Netherlands, you will have to come with good quality goods. They rather pay a little more, also the insurers, for a good product. Then they have experience with bad products, bad disposables, which you need to change more often. And so they go for quality, but they want the quality for a good price. There is an increasing need in investment because hospitals are currently going into a very trend to have everything digitalized. So there is a big ICT drive and also a big drive to additional equipment. There is a market pricing ongoing for cost reduction and delivering patient care. So hospitals are some sort of competing amongst each other for the patient. On the other hand, there's still waiting lists, so patients also choose hospitals in which they get treated earlier. In the hospitals, there's a trend to reduce the amount of suppliers because earlier on they had basically every brand, and currently they're trying to organize that they have less brands and buy more at one stop. Then we also have a trend that's going to more specialized clinics. I named the Martens Clinic. That's a purely orthopedic clinic. That's the only thing they do. So they only do hips and knees and that sort of stuff, back surgery, but they don't do anything else. And we see some private profit organizations coming into play as well. There's some American attention. They want to buy smaller hospitals and get them specialized. And that's the same with private equity. They are looking in interest in the Dutch healthcare market because they think they can earn money there. So next to that, you will see what I told you earlier, care and cure providers, they are competing for at the insurance level for the patient and for the money, obviously. Inefficient sectors will face disruption. So hospitals who do certain treatments very little, they don't get well at it, so they will be challenged to stop doing that. So there's a change in focus in the hospitals. The first line, the general practitioner, is increasing importance as a gatekeeper. So if you get sick in the Netherlands, you go to your general practitioner and they will pull you through to the hospital. If the general practitioner can do it themselves, they will try to do it themselves. So, for example, diabetes, cardiovascular risk management, COPD patients are mainly treated by the general practitioners in care groups. Then we have a reduction of coverage and base insurance. So consumers can, let's say, buy also their own product. So if you want something better, you can buy it, but you need to pay it for yourself. It won't be insured. Currently, the spread about medical technology and pharmaceutical products is about, there's about 7 billion ongoing for pharmaceutical treatment, and currently around 5 billion ongoing for medical technology in the Netherlands. Well, what is the biggest change for this market currently? And that's the change of the MDR. And the medical device regulation is a European law, which is obligatory in the Netherlands. And the Netherlands subscribe to it. So the companies entering the European market and also the Dutch market must have an MDR audited quality management system, and your products need to have a CE by the MDR. If you have done a CE by the MDD, the former regulation, you will have 3 years to change it over to an MDR regulation. But that means you need clinical evidence, so you need more data. You need to have post-market surveillance plans. There is discontinuation and you need fresh clinical data. So you cannot say, well, we did a study 20 years ago. That's not good enough. There will be post-market surveillance necessary. So you will need to show that you're doing that. And the clinical evaluation is very, very important. So it makes entry in the European market not easy. On the other hand, once you're in, and you have a good chance of staying there and have a good financial reward for that. This regulation has increased cost for the industry. It also has done something else. Some suppliers have stepped out of the market. They said, well, it's too complicated for us to abide by the MDR, so we will leave this market in Europe for now. Okay, then we also, next to MDR, we have Euramed. That's going to be a European integrated electronic system. And in that electronic system, they want to have every device in the European market will have a European unique device identifier. So every device will need to have that also on the packaging. If you sell, let's say, class 1 products, you will have the UDI, you will need it in 2025. If you have a class 2 product, you will need to have it in 2023. And if you have a class 1 product, or class 3 product, you will need to have it 2021. So you already need it. The certificates need to be issued by the notified bodies. You'll probably know that, and it's becoming more important. Euramed will be publicly available. So let's say every patient has a chance to see if everything's correct stated. So then, if you play a role in the European market, you will have to work with your notified body more. There are not too many notified bodies currently available, so you will need to check your notified body if they are MDR approved already. There will be scrutiny on high-risk devices, so they will check very thoroughly there. And you need to check if your notified body is also already ready to do MDR things. You need thorough testing and regular checks on your manufacturer. So if you have components coming from elsewhere, you need to show that you test that. There will be unannounced factory inspections. And based on that, you will see that it's difficult for the companies to work with that, but it's also difficult for the notified bodies. So some of the notified bodies also stepped out of the medical device area. Well, now on to the COVID-19 effects. So we as the FHI, we housed LCH, that's a national consortium for supply of medical goods, which was put up by the government when COVID first struck, because all of a sudden there was a shortage of everything. There was a shortage of personal safety devices. We had no mouse masks. There were shortage of gloves and everything. So the government said, well, we want to make sure that everything is divided equally over the Netherlands, and mainly that people who are working with COVID patients got optimal security. So for around 6 or 7 months, this consortium was working from the office in the FHI. So we have a very, very close connection to the government with that. And we were able to play a role in that crisis. All the goods at that time were purchased centrally for this period. So around 6 months in the Netherlands, the companies helped out, played a role in purchasing, but everything was purchased centrally. Then they worked together with KLM to get everything in on time. So KLM had specific flights to China, Taiwan, and everywhere to get the goods in. Currently, the approach in the Netherlands is focusing on vaccination. So we're only focusing on vaccination. The drive is to get every Dutch person over 20 years of age vaccinated before July. And are we going to make that? Questionable. Probably it will be end of July, but will be especially before before September. I think everyone in the Netherlands who wants to be vaccinated will be vaccinated. Next to that, there's been a very big drive towards testing. So if you sell testing strips, testing disposables, it will be an area of interest. And what we also do is we do some field labs to see what is possible. So there are being tests done on restaurants, on cafes, on public meetings, to see what's happening, how people are moving, and to learn from that. If you look into the market structure currently, you will see you have buyers in hospitals, you have home care providers, private clinics, and insurance. That's basically the group you are. You're always in the Dutch market, you're working with experienced people who are doing that buying process. So it's important to have a professional organization yourself as well. The hospital market is about 50% of this. And those sales basically go to direct sales organizations of the larger companies. All of them are direct in the Netherlands. There are distributors, large and small. So if you have, let's say, add-on products or products in which you say, well, it's not valid to start our own organization, I would urge you to go to a distributor. And there's also parallel imports. So if goods are cheaper in Germany, buyers in hospitals tend to buy it in Germany or somewhere else. That's going back and forth a bit. So what you will see that in the Dutch market or in the European market, you will see that there is a trend of going to some sort of harmonized pricing models. The main suppliers in the Dutch markets are large medtech and disposable companies. So the disposables are not too often done directly by the companies. There's always large distributors for that, but the large medtech companies are doing all direct business. The origination from the products being used in the Dutch market are Dutch, obviously, because we do want our own products. So Philips has a big stake in the Dutch market. There are USA-based products, German products, and European-based products. But there are also a lot of products from China, Taiwan, Korea, and others. So basically everything you can get on the international market plays a role also in the Dutch market. For Taiwanese suppliers, the initial way of going to the Dutch market is really go and talk with some distributors. Get your volumes in order there, and from there on you might go to a direct organization. Since everything in Europe is different, right? So we have a European unity, but healthcare systems in Germany, Netherlands, and Belgium are everywhere they're different. So the easiest way for you is to work with a distributor because they will know that market. And don't get fooled by distributors that can tell you, we will do all the markets in Europe. They basically never can. So find a good distributor in a country. You will have distributors for the Benelux, so Belgium, Netherlands, Luxembourg. That's a unity. You have distributors that do the Nordics, but you will need one for Germany. You will need one for France. You will need one from Spain. So there you need specific distributors. Current market needs. There's one big market leads in the Netherlands. The biggest market lead at this moment is gloves. Sterile gloves, disposable gloves, everything. This is the biggest shortage. If you have gloves, you will be able to enter this market and be very profitable in a very short while. Next to that, there is still small shortage on protection articles, not as much as it was. So, but there is interest in that. There is interest in breathing and ventilation disposables, and with that we call breathing set, but also breathing testers and trainers. So the trainers are very important because a lot of the COVID and post-COVID patients are being treated at home, but they need those trainers. So if you have them, that's a product which is very well sellable in the Dutch market. Most other products are well available, but well, as you know, it's a competitive market, so you can always play a role in there. Well, this concludes my presentation for you. I want to thank you, and I will be happy to help you out more if you have questions arising from this. Thank you very much.
今天的研讨会到此告一段落，感谢我们所有的讲师以及各位观众的参与。欢迎填写本活动问卷，问卷连结位于今天影片下方的资讯栏。谢谢大家，我们下次见。